Am I live? There we go. It feels like it's not. Let's move the microphone closer. There's my timer. It is over. Thanks. Thanks, timer. Oh, wait. That's my... Okay. Yikes, sorry. There's that. There's my live. I am centered and beardless. That will work. Okay. So last time on Friday in class, we started into the hypersensitivity mechanisms, the various types of hypersensitivity. These are our diseases of the immune system. We're going to go through a number of them, starting now. All right, here is my presenter screen. Okay. So we went through this. This is the cartoon for the basic mechanism of how hypersensitivity type 1 happens. You get exposed to an allergen, an antigen presenting cell ingests it, presents it on the class 2 major histocompatibility protein, and the helper cell, Th2 here, is samples it and then releases interleukins, activating B cells. The B cells will proliferate, differentiate into memory and plasma cells, which will secrete the IgE, and the IgE will bind to mast cells and the FC region, so they're sticking out. And then subsequent exposure to the same allergen will induce the mast cell to release inflammatory molecules, resulting in the cascade of reactions that results in allergy symptoms. Next, here we go. Some of the preformed components of the mast cell granules. They can release some heparin, histamine, serotonin. Here are their activities. So the heparin will stimulate the generation of bradykinin, which causes increased vascular permeability, vasodilation, bronchial constriction, and increased mucus secretion. I'm sure we've all experienced that. And then the effect of histamines, smooth muscle contraction, increased vascular permeability, increases mucus and tear formation. Again, familiar, right? And then serotonin, increasing vascular permeability, causing vasodilation and smooth muscle contraction. So newly formed chemical mediators. Hey, Bruce. Oh, Bruce, I didn't shut you out. Come on, come on, come up. Oh, can you be seen? I don't know. Show people our dog. Since you're here and I gotta run you out anyway. Come here, Bruce. Bruce, come here. You're up. I know, you're not supposed to get up. Oh, come on. Oh. Can you be seen yet? No. Here. Woo. Who's that dog? Who's that? Oh, God. Okay, sorry. All right, you can go lay down. You're being nice and quiet. Go ahead, lay down, buddy. Okay. Let's see. Viewer 0. Okay. Hypothetically, you're watching this later. Okay, so anyway. So we have the preformed components and then the newly formed components that are generated in response to the inflammation signals as transmitted by the preformed components. We have leukotriene, causing smooth muscle contractions and mucus secretions, increases vascular permeability. Prostaglandin, of course, smooth muscle contractions, vasodilation, and then tumor necrosis factor alpha, which is a cytokine causing inflammation directly and stimulating cytokine production by other cell types. So type 1 hypersensitivities, some common names for these that you or people you know have experienced. We have asthma as induced by allergy. And this is constriction of the bronchi, labored breathing, coughing, chills, body aches, are the signs and symptoms. Anaphylaxis, of course, a systemic reaction to allergens, and this can include this is a systemic reaction, so it includes a whole lot of whole body symptoms, including hives, itching, swelling, tongue and throat, nausea, vomiting, low blood pressure, shock. Hay fever, I'm sure we've all heard of that. That's an inhalation of mold or pollen. I just taught Quinn what pollen actually is yesterday, and he was a little bit horrified. Need to get him past that. So hay fever symptoms include runny nose, watery eyes, sneezing, and there's plenty of over-the-counter medication that promises to remedy most of these symptoms and signs. So hives, more formally urticaria, food or drug allergens, insect stings, and raised bumpy skin rashes with itching. The bumps may converge into large raised area. I used to have that. I used to react strongly to mosquito bites and certain other kind of insect sting or bites, but that's mostly gone away. I mean, like bad swelling, like emergency room the first time that happened, but not to the point of anaphylaxis. I've not experienced anaphylactic shock. Now, there is a perspective that describes what the evolutionary function of the type 1 hypersensitivity might be. And the thought in general is that the hypersensitivity is possibly selected for due to interactions with parasitic worms. We used to have a very intimate relationship with a large number of parasitic worms, and there are still populations in the world that do. But here's the lines of evidence or thought going towards that hypothesis. So we have observed that type 1 hypersensitivity persists in population. IgE, the immunoglobulin that's involved in the type 1 hypersensitivity response, tends to favor binding with proteins that are expressed by helminths. Helminth infection at young age correlates with the reduced likelihood of type 1 hypersensitivities later in life. So a hypothesis, it's out there. And now you're aware. Moving on to type 2 hypersensitivities. This is primarily involved in blood, either vertical transmission of antibodies from mother to fetus or through transfusions. These are mediated by the immunoglobulins G and M. It involves binding to cell surface antigens or matrix-associated antigens involving complement activation and anti-dependent cell-mediated cytotoxicity. The common types are the hemolytic disease of the newborn and hemolytic transfusion reaction. So the IgG from the mother does cross the placenta, and if the fetus's blood is different, has different cell surface antigens, or talking about the blood group, then the fetus's red blood cells get targeted for destruction. This can result in death ultimately, but anemia, edema, enlarged liver, spleen, high drops, fluid in body cavity. And then the transfusion reaction, fever, jaundice, hypotension, disseminated intravascular coagulation, possibly leading to kidney failure and death. This is where the donor red blood cells are being targeted for destruction. Since we make sure to clean the blood before we donate it. This isn't like tapping a vein in one person or an artery in one person and just shoving it into another person, because that would bring all the donor antibodies as well that are circulating in blood. I don't know, that's a weird tangent. Okay, so a look at ABO blood group incompatibility. We have A, B, and O. And this refers to the protein receptor that's modified by glycoproteins and does show dominant or codominance and inheritance. If you get the genes for the A blood type and the B blood type, you will have AB. They will both get expressed. If the genes are effectively broken, you won't get these modifications, so you'll have neither, and you'll have O-type blood. So let's see, the isohemagglutinins, the IgM in plasma that cross-react with blood group antigens not present on an individual's own red blood cells. So if you have A blood type, like I do, you will also have circulating IgM that is anti-B, because you possess the A antigen if you share this blood type. Converse is true for B. You'll have anti-A. You have the B antigen. If you have an AB blood type, both are recognized as self, so you do not generate the isohemagglutinin against either normally, but you have both antigens present. If you have neither, you wind up with anti-A and anti-B, but you have no antigens on your red blood cells directly. So when there is a conflict, we have the hemolytic transfusion reaction cartooned here. And here we have a type A donor. Obviously the blood types were not matched. And we have the B recipient who has the anti-A antibodies. So these antibodies will react to the donor blood cells and start binding them together, agglutination. And while that's going on, the complement cascade will be activated, causing hemolysis and release of hemoglobin. So blowing the cells up. So this will lead to hemolytic anemia. And yes, this is what happens in the hemolytic transfusion reaction. Another aspect of blood types is our plus or minus. Now there's more than 50 specificities included in this category, but only one is particularly immunogenic, and that's the row D. If your blood type is positive, which also mine is, I have the RH factor. So RH plus if the antigen is present. Now this reaction requires a primary antibody response rather than having isohemagglutinins already circulating in your blood. So when RH negative mother that has an RH positive fetus, it's a potentially lethal combination. The risk is lower with the first offspring, but any subsequent offspring, the potentially lethal reaction is more likely. We use anti-RH antibodies these days, Rho-D immunoglobulin, RhoGAM. We can use these drugs to circumvent this, and this is why, and a lot of marriage license might still have it on there, your blood types, assuming that you're going to have children, like every marriage certificate probably did assume. I haven't seen a marriage, I haven't filled one out in a whole lot of years, so I don't know if that's still on there. Okay, RH factors. Here's a cartoon for how this works. So the RH plus red blood cells enter into the mother's circulation transplacentally. This isn't, so some tissues will cross back and forth, some blood will, not like a large volume of, but you don't need much to elicit an immune response. So the anti-RH antibodies are produced upon exposure to fetal RH antigens, but this baby is okay because the mother doesn't mount a huge defense after the first exposure. But the anti-RH antibodies remain When she has a second pregnancy with an Rh positive fetus, the maternal anti-Rh antibodies attack and destroy fetal Rh blood, Rh positive blood, and the fetus becomes hemolytic. If she gets the anti-Rh antibody treatment, so Rho-D during pregnancy, the Rh positive red blood cells enter into mother's circulation. The anti-Rh antibodies bind and inactivate the fetal Rh antigens before they stimulate immune response in the mother. That's why it's not a huge issue now in places that have access to drugs like this. So type 3 hypersens. So type 2 primarily concerned with the blood, most commonly, and by blood type or Rh factor. Type 3 hypersensitivities. Looking at the Arthus reaction, this is a possible outcome of certain vaccines. The risk is really low, but particularly with tetanus toxoid, there's a chance of inducing this kind of reaction. And this was first described in 1903, I think it was. So this is expressed as localized tissue damage, where we have excess IgG relative to low concentration of antigens, causing the formation of immune complexes that are deposited on epithelial cells lining the inner lumen of small blood vessels or surface of tissues. So the steps here, we have IgG binding to antibody receptors on localized mast cells, causing mast cell degranularization. So we're releasing all these inflammatory molecules. This induces complement activation through the alternative pathway, C3A and C5A, resulting in increased blood vessel permeability with chemotactic recruitment of neutrophils and macrophages. Now, this is a localized reaction. There's a more generalized reaction called serum sickness, and this is possibly induced by vaccines produced in animals, certain drugs, microbial antigens. So vaccines aren't the only way to have serum sickness. And in the case of microbial antigens, we're talking about those that are continually released over time during a chronic infection, such as chronic viral hepatitis or subacute bacterial endocarditis. So here's the cartoon for this. We have these antigens, the IgG. They form these immune complexes because there's a lot more antibody than antigen. And we will induce, so in the mast cell degranularization, C5A, C3b, all this stuff going on here. So this can result in damage, specific damage in specific tissues, such as heart, joints, skin, kidneys. If the kidneys are damaged by this kind of hypersensitivity, dialysis may be required. So here's a little Microconnections talking about diphtheria antitoxin. Oh, I didn't reread this. Much less common now than in the past. Right. Toxoid vaccines. So diphtheria antitoxin produced in horses is one example of such treatment that is still used in some parts of the world. Although it is not licensed by the FDA for use in the United States, diphtheria antitoxin can be used to treat cases of diphtheria, which are caused by Corynebacterium diphtheriae. Treatment is not without risks. Serum sickness can occur when the patient develops an immune response to non-self horse proteins, unless you're a centaur, and horse proteins are self. Immune complexes are formed between the horse proteins, circulating antibodies, when the two exist in certain proportions. These immune complexes can deposit in organs, causing damage such as arthritis, nephritis, rash, and fever. Serum sickness is usually transient with no permanent damage unless the patient is chronically exposed to the antigen, which can result in irreversible damage to body sites such as joints and kidneys. Over time, phagocytic cells such as macrophages are able to clear the horse serum antigens, which results in improvements of the patient's condition and a decrease in symptoms as the immune response dissipates. Moving on to type 4 hypersensitivities. We have 3 subcategories of type 4 hypersensitivities, and these involve, so type 1 involves a soluble antigen, and it's activated macrophage damage tissue and promote inflammatory response. Let's see, effector, but this is like contact dermatitis, like the allergy to latex, and the tuberculin reaction, which is the test to see if you have tuberculosis. And subcategory 2 involves eosinophil recruitment, activation, and release of cytokines and pro-inflammatory chemicals, chronic asthma, chronic allergic rhinitis. And then subcategory 3 involves cytotoxic T-cell mediated cytotoxicity. This is also can be involved in contact dermatitis, such as with poison ivy, and tissue transplant rejection. So these are not mediated by antibodies. They're regulated by T cells involving effector cells. So poison ivy, if you've ever had contact with it and didn't have a reaction, good for you. Don't press your luck. While some people might be permanently immune, repeated contact with this antigen just increases the chance that this reaction might occur later. So if the antigen does not get taken up via the dendritic cells, teaching the T cell about it, making a memory helper T cell, and meaning that on secondary exposure, the memory helper T cell will interact with the hapten antigen urushiol. Damn it, I should look that up right now. I will do that. Oops. Okay. Let's go to here. There we are. Urushiol. That's what I guess what I'll call it. Here's it is on Wikipedia. So the R group, of course, means any number of different chains attached here. Urushiol-induced contact dermatitis, which a number of us, I'm sure you've already had this. The bad news is that future contacts can be worse. But again, if you've managed to avoid this so far, just try to keep avoiding it. Now, this reaction is leveraged intentionally in diagnostic testing, and this, uses, okay, so this is the Pirquet scarification, and this is the Tyne test, specifically using a device like this to administer tuberculin antigen into the skin, usually the inside of the forearm. The Tyne test is considered less reliable than the Mantoux test, which when you get this, if you work in a school system or something, you'll be required to get this test. As a healthcare worker, doubtless you're required to get this test. Tuberculin skin test, looking at the PPD reaction. So these are the conditions under which you'd be considered positive if the resulting bump. So you get the jab, they inject the tuberculin under your skin, and you come back 48 or 72 hours later, and they examine the injection site. It would be considered positive at just over 5 millimeters, or equal to if you're HIV positive, recent contact with an active tuberculosis patient. These conditions over, equal to, or greater than 10 millimeter under these conditions. Oh, mycobacteriology lab personnel. So if you work with mycobacterium, well, that makes sense. Children under 4 years old. And then the reaction has to be much more exaggerated if you have no known risk factors for tuberculosis. If you've had the vaccine, is that on here? I don't see it. If you've had the vaccine, you might have a positive reaction as well. So hypersensitivity, pneumonitis. This is a multifactorial hypersensitivity. This is where we lump all of these diseases that are associated with certain occupations or environmental exposures. And if you're in Western Kentucky and you know anyone that's worked in the chicken plant, they most likely came down with like a cold type of illness that lasted for a little while and then they got over it. That would be, so it happens to mushroom pickers too, hot tub lung, farmer's lung. It's probably going to be in the manufacturing testing. I don't know. Bird fancier's lung, if you work with a lot of birds, just a continued exposure to allergens, to dust, molds. Here we go. There's a picture for this. Poultry worker's lung, that's what they call it. And then cheese factory, they may be sensitized to different types of molds and develop cheese handler's disease. Sorry, that shouldn't be funny. It just sounds a tiny bit funny to me right now. Okay, the next slide. We're looking at a summary of hypersensitivities and their mechanism. So type 1 is distinct from the others in part because it involves the immunoglobulin E, whereas 2 and 3 involve IgG and IgM. And type 4 is a T cell, so Th1. So type 1, we're looking at local systemic anaphylaxis, seasonal hay fever, food allergies, drug allergies. Type 2, and that's with the blood, specifically transfusion or hemolytic disease of the newborn. Type 3 involves, we're going to talk about these. These are type 3 hypersensitivities. So some lupus, rheumatoid arthritis, am I going to talk about that? We'll see. Glomerulonephritis, that is post-streptococcal. And then type 4 involves contact dermatitis, type 1 diabetes, mellitus, and MS. All right, so the prick puncture skin test. If you have allergies and you've been to an allergist, they might have done this, where they prick your skin with various antigens to figure out what you're allergic to. And a positive result is, of course, a raised area and surrounding redness, so wheal and flare. Treatment involves desensitization. Sometimes when I'm saying things, the slight delay in my monitor here makes me trip up on what I'm actually saying. So this involves repeated exposure to a dilute known allergens over time in hope of inducing allergen-specific IgG that can act as blocking antibodies, preventing allergen from reaching the IgE on mast cells. If you recall, the IgG is a lot more represented in the antibody pool, so you have a lot more of this IgG than you have the IgE. And so if you can block the antigen before it can activate these mast cells, then you'll be effectively desensitized. Epinephrine is used to counter the drop in blood pressure due to extreme acute systemic anaphylaxis, and we use antihistamines or other anti-inflammatories to try to block some of these signaling molecules to interrupt that hypersensitivity reaction. Benadryl. I was a big friend of Benadryl when I was little. so autoimmune disease. So the causes of autoimmune disease in general are not well understood. It's thought to be a combination of genetics and the effect of environmental influences. Pollution can be one of those. Pollution that your parents or even grandparents may have encountered. That's good news, right? Only a few specific diseases are the initiation events characterized. You can have a loss of immune tolerance, including 2, 3, and 4 hypersensitivity reactions. Regulatory T and B cells play a role. And then you have to worry about antigen mimicry. So some types of autoimmune disease can be from an antigen that you encountered that mimics something that is a self protein. Okay, this isn't exactly that, but the alpha-gal allergy that's communicated by the tick is a kind of antigen mimicry, because that meat sugar isn't something that you should encounter in a tick. Organ-specific autoimmune diseases include celiac disease, Graves' disease, Hashimoto thyroiditis, type 1 diabetes mellitus, and Addison disease. Celiac disease it can begin at any age, mostly people in their 30s, 40s, and children. This involves having an inflammatory response to gluten in the small intestine. It can cause a reduction in the microvilli depth. It can cause weight loss, anemia, diarrhea, and abdominal pain. So it is diagnosed by a serological test for the IgA that is reactive to gluten. And then they can use endoscopy and biopsy of the duodenal mucosa to diagnose it completely. And you treat it by removing gluten from your diet. There is work currently being done to modify grains to lack that immunologically reactive component, as well as dietary supplements to help. So something else that's commonly reported around celiac disease is the relationship between celiac disease and autism. There isn't one. So this nationwide study of the association between celiac disease and the risk of ASD, and conclusions and relevance include: although this study found no association between CD or inflammation and earlier ASDs, there was a markedly increased risk of ASDs in individuals with normal mucosa but a positive celiac disease serologic test. Now that's from November of 2013. Yeah, so basically no. There's not a direct relationship between the two, as in a causal relationship, but there is a slight correlation with the serologic test result and autism. I'd have to go back and look at the article. It's been a while since I actually read this, but I would want to evaluate whether or not there was a sampling bias possible there, because a lot of people get the idea that autism in their children is related to celiac disease, so they might be more likely to get them tested. But I don't know that. I'm just speculating. In very recent news, there is currently a clinical trial going on that they're calling a vaccine for celiac disease, but it's not. It's a desensitization. They're desensitizing people. Yes, so it's not really a vaccine. But as you see, this was reported here on November 9th, so last week. So the vaccine is intended for patients with CD who have a particular immune gene, and it's HLA, which should sound familiar, the prefix anyway, DQ2.5. and that's 90% of the people with celiac disease have that gene. This company that's working on this, they're calling it NextVax2 in their phase 2 clinical trial. So what it would be. So they had 150 people in the study. Oh no, it's the new study. So maybe that's supposed to be their phase 3 or just another phase 2. Anyway, the earlier trial showed that the vaccine was safe and well tolerated among patients with celiac disease. Oh, that was phase 1. So they're moving into phase 2 now. And they're doing a recruitment for this now, actually. So if you or someone you know has celiac disease and would like to be included in this clinical trial, clinicaltrials.gov is a website you can go to check it out. Okay, so disorders of the thyroid. I mentioned Graves' disease earlier. It is a type of hyperthyroidism, and this is where so production of thyroid stimulating immunoglobulin, TSI, or TSH receptor antibody binds to the receptor for thyroid stimulating hormone. It can cause either overproduction of thyroid hormones or inhibit production. Hypothyroidism, on the other side, we have Hashimoto thyroiditis, and this is Th1 cell mediated disease causing thyroid to be attacked by cytotoxic lymphocytes, macrophages, and autoantibodies. Here is an expression of a goiter. That's hypertrophy of the thyroid. That's the symptoms of Graves' disease and Hashimoto thyroiditis. It's another symptom. So exophthalmia. It's a sign of Graves' disease. So type 1 diabetes. Diabetes mellitus, juvenile diabetes. This is a T-cell dependent autoimmune disease that results in the selective destruction of beta cells on the islets of Langerhans. Weird Al has a song called Pancreas that can tell you about this. Well, not about diabetes, but about the islets of Langerhans and the things that these cells secrete. So this is by CD4-Th1 mediated CD8 T cells. And this involves anti-beta cell antibodies and macrophage activity. Viral infections can have a potentiating or inhibitory role in the development of type 1 diabetes. Interesting side note. So Addison disease, primary adrenal insufficiency caused by damage, destruction of the adrenal glands. 80% of cases of Addison disease are diagnosed as autoimmune. Both humoral and CD4-Th1 driven CD8 T cell mediated immune mechanisms are involved. There is evidence supporting autoimmune response associated with autoimmune destruction of other endocrine glands. Symptoms include all these things: weakness, nausea, decreased appetite, weight loss, hyperpigmentation, everything listed there. Hyperpigmentation looks like this in the case of Addison disease. All right, so moving on to systemic autoimmune disease, multiple sclerosis. This is an autoimmune central nervous system disease that affects the brain and spinal cord. Lesions occur in multiple locations within the CNS and that are caused by the infiltration of immune cells across the blood-brain barrier. Immune cells include T cells that promote inflammation, demyelinization, and neuron degeneration. Here is we're in phase 2 trials. Should see where they're at right now. If I have time at the end, which I might not, I could come back and look at that. So this is using immunoablation, which sounds really cool, and on autologous hemopoietic stem cell transplantation for aggressive MS. Now, this was tentatively a positive outcome in this phase 2 trial. I want to see now, because I forgot. Nope. I have to go back to here again, open this up. Whoop. Where am I at? Okay. Dynamic. I want you to stay up here, and I want this up here, so I can do this. Let's see what this says right now. Findings. 167. Okay, the primary outcome, MS activity-free survival at 3 years after transplantation, was 69.6%. I said at 95%, and there's its confidence interval. After 13 years of follow-up, no relapses occurred. Nice. The rate of brain atrophy decreased to that expected for healthy controls. 1 of 24 patients died of transplantation-related complications. 35% had a sustained improvement in their expanded disability status scale score. Describe the first treatment to fully halt. Furthermore. So I don't know how far this has gotten from here. And this trial has been going on for years. All right, anyway. Sorry, I forgot what the outcome of that was. All right, Myasthenia Gravis, another systemic autoimmune disease. This is where we have anti-acetylcholine receptor antibodies that are blocking acetylcholine receptors at neuromuscular junction, inducing complement activation there. And this is, well, it causes paralysis. This is on the other side of the cell wall, of the cell membrane here, where the botulinum toxin, botulin, inhibits the acetylcholine on this side of the cell. And this disease causes inhibition on the other side. So this would be cause a flaccid paralysis as well. All right, so we have psoriasis. Is an systemic autoimmune disorder that results from a complex interplay between keratinocytes, dendritic cells, and T cells, causing cell turnover to happen in days instead of a month as a result of cytokine activation. Rheumatoid arthritis involves type 3 hypersensitivity reactions and the activation of CD4 T cells, resulting in chronic release of the inflammatory cytokines, interleukins 1, 6, and TNF-alpha. The activated CD4 T cells also stimulate the production of rheumatoid factor antibodies and anti-cyclic citrulinated peptide antibodies, anti-CCP, that form immune complexes. Increased levels of acute phase proteins such as C-reactive protein are also produced as part of the inflammatory response, the process, and participate in complement fixation with the antibodies on the immune complexes. And this is what this can look like. We have systemic lupus erythematosus. This is caused by a type 3 hypersensitivity reaction where antibodies are produced that are directed against nuclear and cytoplasmic proteins, self-proteins. Anti-nuclear antibodies, ANA, are present in more than 95% of patients with lupus. So you can have anti-double-stranded DNA, anti-small nuclear ribonucleoprotein antibodies. They're unique to SLE. Most common symptoms include fatigue, fever, hair loss, sunlight sensitivity, butterfly or wolf mask rash, which I think is pictured here. Yes. All right, now here's a summary of all these autoimmune diseases, which I'm not going to read. We have about 4 minutes left at most. I wanted to address this issue. We have organ transplant and rejections. Oh wait, I can go back up here. So this is in the book. You can, that's free to everybody. It's the OpenStax microbiology book. For anybody else that's not in the class that might watch this. Okay, so types of tissue and organ grafts and their complications. So self to self, no rejection to worry about. So butt skin to head skin or whatever. Isograft, if you have an identical twin, you can borrow parts from. There is little concern of rejection. An allograft is a relative or non-relative to an individual. There's possibility of rejection. And of course, a xenograft from animal to human, larger possibility of rejection. So this involves MHC class 1 and 2. If the transplant is recognized as non-self, it will be attacked. Now, because of the highly polymorphic nature of the HLA A, B, and C genes, there's a low probability of compatibility in a random population sample. So that high variability that makes our immune systems more robust also makes transplantation more difficult, which makes sense. So graft versus host disease. So in the recipients of bone marrow and peripheral blood stem cells, the donor's T cells attacking recipient cells. In the GI tract, liver can damage the eyes, can cause a cytokine storm. HLA matching is critical. Many donor antigen presenting cells and T cells are removed as possible. In the future, maybe we will grow human organs in animals, so we can just, customize our transplants a little better. Another option that we're not near prime time yet, but the idea of using a 3D printer to print tissues, and the goal of printing an organ. And we can do it with something like an ear, but that's as far as we've gotten. There's a group that I think has done a heart and that will contract, but nowhere near strong enough to transplant into an animal. So immunodeficiency can be inherited or acquired. It's mostly inherited in developed countries rather than acquired. There's primary immunodeficiency, more than 250 types. These are inherited defects to either non-specific innate or specific adaptive immune system. Most become apparent shortly after birth. We have chronic, let me see how much is left here. Not much, okay. I might summarize a little bit more. So we have chronic granulomatous disease. Defects in NAD/pH oxidase system of phagocytic cells. Neutrophils and macrophages can't produce superoxide radicals. X-linked A-gamma globulinemia. Defective in differentiation in B cells, so you lose the ability to produce specific antibodies. Selective IgA deficiency is the most common form of immunoglobulin deficiency. People with it are prone to lung and gastrointestinal infections. Severe combined immunodeficiency, this was the boy in the bubble. He lived most of his life inside a plastic bubble. NASA made him a suit to walk around. Fortunately, he died at the age of 12 due to a latent Epstein-Barr infection in sister's bone marrow. X-linked SCID is the most common, involving B and T cell defects. So secondary immunodeficiency is acquired impairment, like diabetes mellitus, malnutrition, hepatitis, HIV, immunosuppressive treatments if you got one of those transplants, and prolonged critical illness due to infection, surgery, or trauma. AIDS is the best known. World malnutrition is the most common cause of secondary immunodeficiency worldwide. And this table summarizes these things. And we're going to go on. Let's see. Cancer, immunobiology, and immunotherapy. The lack of MHC1 presentation is common adaptation in cancer, in that the tumor is able to evade the immune system. Cancer vaccines. We have preventative, the HPV vaccine, hepatitis B, and then therapeutic, tumor-specific antigens, and oncolytic viruses. That's a whole nother topic where we're working on modifying viruses to target tumor cells for destruction. And I'll go over that another time, I expect. All right, that is going to be it for today. I will see you on Wednesday. I don't have a smooth exit yet. I have to go to